This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Thank you. This is sort of a broad topic, so I've kind of tried to narrow it down on things that I think are of interest to people. And in fact, the disease has been around since antiquity. In fact, some of the treatments we still use were actually conceived in antiquity, and I'll show you that as well. One of the things that I find when I see my patients is that they confuse the term vein and artery. They're completely different structures. Most people think they're arteries or veins. They're not. Arteries are very discrete structures that actually conduct blood to the extremities, to the heart, to the brain. They are high-pressure systems. They're very non-compliant. They're very elastic, whereas veins are low-pressure, low-compliance. And it's important in how we as humans function, because when you stand up, you can imagine the hydrostatic pressure that would build up in a tube. If you just hung a tube from the ceiling filled with water, there'd be a lot of hydrostatic pressure at the bottom. And it's because of the unique nature of the vein being very compliant, being able to accommodate big volume changes without changing the pressure, that allows us to assume an upright position, and in most normal situations not have any problems with venous insufficiency or venous hypertension. This cartoon sort of illustrates the drainage that is typical for the venous system. Underneath the skin are small dermal and epidermal venules that then drain into the larger subcutaneous veins, which are of importance when we're talking about varicose veins. And then we drain through these perforating veins into the deep veins. So the important thing for this talk is the concept of a superficial vein, a perforating vein, and a deep vein, all of which have valves. In the deep venous system, most of the valves are located below the knee, and that's an important concept as well. So when patients develop blood clots in the deep veins, that can often damage the valves deep in the calf, and that's what leads to some of the severe symptoms of venous insufficiency that we'll talk about a little bit, and some of the therapies that are directed towards that. Similarly, after a blood clot in a vein, whether or not it opens up completely or not, can damage these perforating veins, and now you have this higher pressure deep venous blood trickling back into these superficial veins, causing incompetence of these veins, and those are what we see as varicose veins. This is that dynamic pressure curve I told you about. So if I laid you down and I measured the blood pressure in your foot, it would be very low. If I then had you sit up and drop your feet over the edge of the bed, you'd see that the pressure begin to rise until when you're standing, pressure is quite high, and this really is equal to the column of blood formed from your heart down to your foot. If you take one step, there's a dynamic process within your extremity, both on stepping over the foot, starts initiation of blood flow back to the heart, to a large venous lake in the bottom of the foot. Then the muscular calf has a very tight envelope around the muscles, and that allows the muscles to contract, but it constricts the space. Therefore, the muscles pump or evacuate the blood out of the calf up towards the head, back towards the heart, and you see a rapid drop in the blood pressure. In disease states, if there's obstruction, this can't happen. You can't get rid of this high blood pressure, and that's one form of venous hypertension. Similarly, if the valves don't work, this pressure comes back very quickly because the valves aren't competent, and that's what we'll be talking about later. So venous disease really is broken up into three categories. Important to today's discussion is reflux, but occasionally we do have obstruction, which can be caused by deep vein thrombosis or partially resolved deep vein thrombosis, or from extrinsic compression, such as mass effect, bands, tumors, simple things as fibroids. There are compression syndromes known as the May-Turner and the Paget-Schroeder, which are beyond the scope of this talk. And some people have a mixture of both reflux and obstruction, and they're the most difficult patients to treat. Well, the interest is about varicose veins. What are varicose veins? Well, they're abnormally enlarged superficial veins. They have absent or failed valves. There's a syndrome called Klippel-Trenaunay syndrome, where they have congenital absence of some of their deep veins, sometimes with some of the superficial veins, and the valves are not normally formed, and those people have massive varicose veins, and oftentimes we can't treat those because they're really the only return they have out of their lower extremity. The absence of these valves leads to stasis or pooling of blood, which increases pressure, and it's that increased pressure that causes your discomfort. It's the stretching of the vein that is what causes the discomfort, and that's why everybody understands when they elevate their legs feel better. They all tell you that my veins ache all day long while I'm at work. The minute I get home and put my feet up, sometimes just on a bed, sometimes they run their feet up the wall, but not if they just leave them in a dependent position, such as in the lazy boy, where their pressure and pain resolve. Complications from varicose veins are rare, but if you look closely enough, we can see some form of a complication from untreated varicose veins in up to 50% of our patients. The most decimated, or the most decimating kind, are the thrombophlebitis. That's a blood clot in the superficial vein, which is not the kind that's going to go to your heart and cause you cardiovascular instability, but is the kind that causes severe pain and discomfort, causing you to go to the emergency room. Spontaneous bleeding from varices is uncommon, but if you have a diseased skin, such as the dermatitis we see in severe stasis, you can lead to spontaneous bleeding, and we've had several patients who come in with a story of looking down the shower and seeing a pool of blood in the bottom of their shower. Well, how common is this? It's very common. Between 10 and 20% of adults in the U.S. and Western Europe will have varicose veins. Up to 50% of women by the age of 50 will show some sign of telangiectatic veins, and I'll describe to you what that is. The classification of varicose veins is really dependent upon the size. So the smallest, the telangiectasia, also known as spider veins, are the smallest, less than 1 millimeter in diameter. The reticular veins, 1 to 4 millimeters in diameter, and a varicose vein described as something larger than 4 millimeters. Here are some clinical examples. This is a spider vein, or a telangiectasia, very, very superficial in the skin, often have one feeding blood vessel that often is a reticular vein that, if injected properly, you can ablate or resolve this process. These are the reticular veins. The larger veins are not truly a varicose vein, again 1 to 4 millimeters, typically located on the outside of the thigh, behind the knee, sometimes on the outside of the calf. Although small, they can be quite painful. They've been treated both with surgical removal as well as some of the sclerotherapy techniques we'll talk about. And this is the true varicose vein. This varicose vein involves the greater saphenous vein, which is one of those major superficial veins running up the inside of the thigh and leading to these secondary. These are actually, I'll show you in a cartoon in a few moments, is a branch of the greater saphenous vein, and they can, over long periods of time, they can become quite large. I have several patients, one particular patient who's in his mid-80s now, I've been seeing since I got to Stanford 16 years ago, who has veins that look like this. He says he has no discomfort. I'm certain that he does. He's just gotten accustomed to it, but he doesn't want anything done about it. And this is the varicose vein of the lesser saphenous vein that typically we see in the back of the calf, oftentimes coursing out to the outside of the calf down towards the outside ankle bone. Well, how do I get them? What did I do wrong? Well, you have a family that gave them to you usually. That's the most common predisposing factor. So you always hear a story of, and it's often interesting that a patient will come in with varicose veins on their left leg, and every family member has had them on their left leg. They can be bilateral, but again, family history most important. What makes them worse? Anything that increases abdominal pressure or decreases venous return. So we talked about that dynamic motion of standing up and walking, which pumps the blood out of the limb. So anything that leads to sedentary lifestyles, lack of exercise, prolonged standing in a job where you can't move, birth control pills which lead to dilation of the veins, increased blood volume, can also lead to it. Obesity, which decreases or increases abdominal pressure by a mass effect similar to pregnancy, and constipation. 33% of patients who have varicose veins will develop them before the age of 25. We see patients as young as 15, 16 years of age with very symptomatic varicose veins. So they're not clearly an aging process, although the symptoms will increase with age. 70% of our population will have some visible leg veins, mostly telangiectasias or reticular veins, by the age of 70. What are the symptoms again? This heaviness, fatigue, achiness, throbbiness, and then more advanced conditions, the dermatitis, which is a dry skin, an itchy skin. Patients begin to scratch their leg, they break open the skin. The skin, because it doesn't drain blood well, is prone to edema. They then get skin infections called cellulitis or erysipelas, which can then damage the skin more, and it's a sort of self-fulfilling prophecy leading finally to ulceration. Ankle swelling is present, but it's not a major component, and I'm very clear with my patients in telling them that if I treat the varicose veins, I wouldn't expect them to see a lot of improvement in their edema, because edema is multifactorial and beyond the scope of this talk. It's also important to understand that the venous insufficiency or varicose veins is a diverse disease. Now, this study back in 1991, in a full third of their patients, they could identify no reflux in those specific veins I talked to you about, the superficial system, the deep system, or a perforating system. The most common source, though, remains the greater saphenous vein, where it connects to the deep femoral vein, the greater saphenofemoral junction right here. But physical examination alone is not specific, and it's not very sensitive. Even when you use a handheld Doppler, which is a little pencil probe that gives an ultrasonic signal that you can listen to blood flow and try and decide the direction of flow and try and decide whether or not there's venous insufficiency, meaning reflux or vein blood falling in the wrong direction, going back towards the ground. In this study, they looked at patients, had an experienced examiner do a physical examination with the aid of a handheld Doppler, and then each patient had a duplex, which is a more specific examination I'll talk to you about in a moment. And the sensitivity was not very good, specifically in finding deep reflux. And if the surgeon were to have operated on these patients based on his physical examination alone, 30% of the problems would have been missed. Well, what is the treatment plan for venous insufficiency? Well, it's removal of this reflux, and wherever it is. And so the important concept is a preoperative assessment of exactly where the problem is so we can direct our therapies to the problem. That means identifying duplications, perforating veins, reflux at any key tributaries, and quantify if there's deep reflux. Because if a patient has severe deep reflux, those major workhorse veins deep inside the leg, and I take out their superficial veins, I may not help them very much, and it's important that they understand that. Well, this is a picture of a color flow duplex ultrasound scan. This is the way the examination is done. The patient is standing with their weight on their non-examined leg. The probe is placed over a vein. The leg is then compressed below the level of the ultrasound, and ideally you see an augmentation of blood flow through the vein that I'll show you in a minute. And ideally, after the blood flow goes through the vein, it stops. That's the normal situation with a competent valve. Now here we have an abnormal patient. This is the saphenofemoral junction. So this is where this superficial saphenous vein joins this deep vein right here. This is the common femoral vein. This little gate right here is where you can actually submit the Doppler signal into this space and assess the flow, and also the direction of flow. This is an old slide. This is a non-color flow, but today we have color flow, and for stupid people like me, it allows you to have blood flow towards the heart in red and back towards the foot in blue. But this is an older version. So here we have augmented flow, so that's flow in this direction, and then it's let go, and you can see that there's a large volume of flow going in the wrong direction. So this is reflux, and these markings, every other marking here is a second, so that's significant reflux. Here is the vein in cross-section, so it's a big vein. That's much bigger. That vein should be about this size down here. Again, mid-segment of the saphenous vein, same maneuver. Augmentation should stop. This should be flat. There should be no signal right here, and again, you have a long reflux, multiple seconds, again, in this very dilated vein. The duplex can also identify these perforating veins and show reflux in the same manner in the perforating veins. So this cartoon depicts the usual anatomy of the saphenous system, and you can see there are multiple branches. Before we had duplex, the procedure, and many in this room may have had one, is an incision was made at the ankle, an incision was made at the groin, a device, nobody knew what it was, but they said some device was passed up and they ripped out the vein. And they had these big old flash incisions all over their leg, and they had varicose veins that came back, and they wondered why. Well, now you can appreciate there are multiple branches, and if sometimes this vein is normally duplicated, so there's two veins here, and if you only stripped out one, the other would be left there, still with the same connection to the deep system, still capable of causing varicosities. Multiple perforating veins that we talked about are isolated, specifically in this area of the thigh, so you'll see a lot of patients have varicose veins in this particular region of their leg, as well as along this corridor right here, where there are three specific perforators. How do you relieve your symptoms? Insurance companies tell you that you don't need to have this done because it's cosmetic. Well, of course it's cosmetic, but it's also functional, and that's the beauty of the ultrasound, is that now I can document in your limb that you have an abnormal physiology and therefore warrants treatment. So that's one of the important things that the duplex provides. But the traditional recommendations for patients with venous insufficiency was to get active, wear compression, lose weight, elevate your legs at the end of the day, And in Europe, there are multiple drugs that have been tried for the treatment of venous insufficiency, sort of venotonic drugs. And it turns out that the major extract that's used in this venostat drug is horse chestnut. So if you really want to try something, go down to your local herb shop and ask them for some horse chestnut, see if that helps. There will be at least a 30% placebo effect in anything you take, so it's worth a try. Well, what is compression? This is not the TED hose. This is not the white stocking that your wife or husband was sent home from after their recent abdominal surgery. These are real, hard, real devices. They're in various grades, class 1, class 2, class 3. There's actually a class 4 that we wouldn't use for this particular problem. They can be custom fit, but typically there are multiple sizes, and the patient is measured with the length from the tibial tuberosity, that little bone that sticks out in the front of your knee, to the ankle bones, and then the circumference of the calf, the ankle, and the foot are measured, and you get a stocking that's relatively custom fit. The concept is you wear this stocking while you're up during the day, you remove it in the evening, and for most people, this will control your symptoms. Oftentimes I'll use this as sort of a test to see if the patient responds, because a lot of people have leg pain. Not all of it is related to venous insufficiency. If you wear your stocking and you don't have improvement of your pain syndrome, it's unlikely that my treatment of your superficial venous problem is going to relieve your pain syndrome. For patients that are more obese, or some patients with severe arthritis that can't apply the stockings themselves, there are some aids to apply it, but there are also some inelastic compression devices. Now, the most common known as the Circade, and I'll show you an example of that. So this is the typical compression stocking, traditionally in brown, but now available in many colors, including blue and white and black, and so they can be somewhat more fashionable, but still they're compression stockings. This is a nylon sleeve that one places over the toes and allows you to slide the stocking on, which is the most difficult, is getting it over the foot and the ankle, or the foot and the heel onto the ankle. And then with an open toe stocking, this can be pulled out. Similarly, you can use a lady's knee-high nylon stocking and slide the compression garment over the top of that. This is the Circade device. It's these multiple interlocking inelastic Velcro straps. So the concept is the patient spends the night with the legs elevated, and we'll talk a little bit about how you do that. And then before the patient gets out of bed, you apply this inelastic compression device from the foot initially up to the knee, and that will keep the edema from reforming in the limb. When I talk about elevation of your feet, you can't go home and put your feet on a pillow. If you've ever watched a video of somebody sleeping there all over their bed and the pillow's on the floor within about a half hour, you can't put a wedge under there because you'll get a bad back. Okay? The simplest way to do it is take a block, a 4x4 block, and put it under the foot of your bed. That's 4 inches. That's all you need. Therefore, if you're a back sleeper, a stomach sleeper, a side sleeper, your foot's always higher than your chest. My father-in-law is in a wheelchair and had severe swelling of his lower extremities, and I tried to talk him into doing this, and he wouldn't believe me, so we snuck into his room and put his bed up on blocks, and the next day he saw his ankles for the first time in 6 months. And when I showed him the blocks, he couldn't believe it. So it really works. Well, as I said, the varicose veins have been recognized since antiquity, and Galen actually recognized that these ulcers that often formed near a varicose vein, and if you remove the vein, it wasn't done on purpose, it was actually, in this particular instance, was done accidentally, the ulcer started to heal. In the 19th century, again, it was recognized this association with varicosities and ulcers and removal of the vein leading to healing. But really the father of modern venous treatments is Trendelenburg. Trendelenburg described the test, again, a physical examination type test, using elastic wraps placed over the saphenofemoral. That's where the main saphenous vein goes into the groin, or the saphenopopliteal junction, where the lesser saphenous vein goes into the knee behind the knee. If you put a tourniquet around that and had the patient stand up and the varicose veins didn't recur, he knew that association meant that that valve was incompetent, and then therefore removing that, ligating that greater saphenous vein would treat those varices. So he was one of the first to perform ligation of the greater saphenous vein. He also excised varices in the 1860s and actually performed the first pulmonary embolectomy in 1908. That's a big operation to be done in 1908. This is Charles Mayo, one of the Mayo brothers, started the Mayo Clinic, but was a surgeon and a pioneer in venous surgery, and his contribution was a very foreboding instrument called the external stripper. It was a big ring on a long metal hook, and it made an incision in the groin, divided the vein, slid this little ring around the outside of the vein, and rammed it down the leg, and hoped that you didn't have a lot of bleeding. And for many years, patients had this done, and they told their friends, don't go see that guy. These two men, Harold Dodd and Frank Coquette, really contributed a lot to our understanding of venous insufficiency in understanding the influence that perforating veins have. Without their, and that's why you notice in that cartoon back there were some Dodd perforators and there were some Coquette perforators, but they recognized that just stripping a greater saphenous vein if they had incompetent perforators didn't always treat the disease, and therefore these incompetent perforators warranted treatment as well. And as we get into some of the newer endovenous ablation techniques, we'll talk about some of the reasons for failure may be because these perforators had not been addressed. Well, the modern era of saphenous vein surgery really changed in 1963 when the concept of invagination stripping was entertained. What we mean by invagination is you actually turn the saphenous vein inside out on itself. A device is passed inside the vein, but it's tied in such a way that when you pull on the stripping device, the vein turns inside out, or inverts into itself, and therefore there's less trauma. The old-fashioned way was to take a big metal initially, and then more recently plastic acorn. It looked like a big grappling hook. It was attached to the stripper. Once you had it there, you started pulling, and it grabbed everything in its path, including the vein. And that caused, as you can imagine, a lot of local tissue trauma. And most patients, the sensory nerve, especially below the knee, the saphenous nerve below the knee is immediately attached to the saphenous vein. And so this maneuver caused a lot of pain and discomfort, and oftentimes a persistent neuralgia that led patients to have lifelong pain. This invagination stripping led to diminishment in that, and then was further improved with the idea of using a bandage that's soaked in lidocaine epinephrine, which is my own technique, which minimizes the bleeding and also gives some pain control as well. The most recent change has been this perforate and invaginate, where actually a small little hook is passed through the skin to grasp the saphenous vein, and little pieces are pulled out rather than one long stripping. Well, as I said, Trendelenburg talked about ligation of the saphenous vein, and many surgeons, even as recently as 10 years ago, performed ligation alone. That's a small incision in the groin, the vein is ligated, and that thought, well, I'll stop the reflux, therefore the varicose veins will go away. This study in Britain, randomized prospective study, looked at patients with varicose veins. Half of them had the stripping procedure with high ligation, half had the ligation alone. And at 3 months, with ultrasound objective follow-up, the majority of patients in the stripping group were cured, whereas a significant number recurred in the ligation alone. So that led many to recommend that high ligation and stripping were important. Everybody worries about recurrent varicose veins. The most common question I receive when I'm talking to a patient about proceeding with the treatment is, will I ever get them back? And I always say you can never say never. The veins that I treat now with the use of ultrasound, I can guarantee you I can get out those veins, but I can't guarantee you that other veins won't develop varicosities over time, because we don't know why varicose veins develop in the first place. Multiple patterns of recurrence can be seen. The panacea, or the marketing of the endovenous ablation techniques, have always cited this recurrence rate with the traditional surgery as a reason not to have it, but what they're really talking about is this neovascularization, which happens also in their own procedure. Residual greater saphenous vein and accessory veins left behind are less common now, again with the use of the preoperative ultrasound. Some of these newer devices are very expensive. This is the device used for the stripping, costs about $1.50. I'm sure Stanford charges about $500. But it's a little plastic device that's passed up the vein. These are those acorns I told you about, but we no longer use those acorns. And this is how the procedure is performed. So a small incision is made above the inguinal crease at the junction of where the saphenous vein, which is coursing in this direction, connects to the common femoral vein. Once the vein is isolated, another incision is made down at the proximal, at the inside of the calf, right below the knee, and this plastic device I just showed you is passed all the way through the vein. It can either be passed from the calf to the groin, which is the traditional way, or sometimes if it can't be, we can pass it in the retrograde fashion because, again, these valves aren't working. This is the bandage that we soak in a solution that contains local anesthetic as well as a vasoconstricting agent. And the idea behind this is this provides a scaffold for the invagination of this vein. And here's the vein after it's been removed. You see the difference in this red appearance here, that's the outside of the vein, versus this white appearance, that's the inside of the vein. And then we leave enough of this bandage on the stripping device so that an equal length of the bandage is staying in the skin while we perform the rest of the phlebectomy procedure, which we'll talk about now. So if I just took out that greater saphenous vein, you'd still have varicose veins, and you would be unhappy. Similarly, if I just ablated your vein with the endovenous ablation device, you'd still have varicose veins. So for a complete procedure, you also need to perform some form of phlebectomy. Phlebectomy means to remove a vein, okay? So the current treatment is what's called stab phlebectomy, and for those knitters and crocheters in the office, in the audience, this is a whole host of hooks that all look much like crochet hooks, okay? And the idea is we make a small incision. We actually use a knife that's used to open up the cornea for cataract surgery, very small incision. You can even use a small needle. With the hook, we elevate the varicosity, and with these hemostats, we can literally advance it out, and with a special cautery device, seal it off. So this is during the process, and this is what the incisions look like when they're done. Fairly small, don't even use sutures to close them. This was from division of the lesser saphenous vein. And so this is a typical patient. You see they had significant varices from the greater saphenous vein. So the saphenous from here up towards the head was refluxing and led to these varices here. So the saphenous was stripped to this level, and then stab phlebectomy was performed. And this is the patient a month later. I talked to you about the varices that are common on the inside of the thigh. So again, this patient had an incompetent saphenous vein that actually stripped down to here, but this branch and this perforator right here made another incision here, and then phlebectomy of this segment. And this is the result. There is interest now in a minimally invasive way of removing these varices. The current version of this is this Trivex system. It's a lot like liposuction. It's this rotating head with a fiber optic light that's placed underneath the skin, and it's designed just to grab all these varices and pull them up. I saw it demonstrated once, and the amount of bleeding I saw was frightful, so I've decided it's not in the best interest of my patients. But it is a device. If you go to some of the vein centers around the country, you'll hear about it. I'm not sure how frequently it's used, because I think there are better options available, specifically the stab phlebectomy. So I'm talking about old-fashioned surgery again, developed in antiquity, refined in the 19th century, and been used steadily for the last 200 years. Is it tarnished? No. It's still a very durable procedure. I think with the innovations that we've talked about, the cosmetic result is improved. Patients who are studied after their procedure feel that it has improved their quality of life, and recurrence is minimized by the use of the ultrasound, and really is disease-related rather than procedure-related, meaning that patients may develop other varices and segments of vein that were not abnormal at the time of their procedure. Well, it's the age of the internet, okay, and everybody wants something sexy. So you can go to Arizona and play some golf and have your veins taken care of by this doctor, who's not even a vascular surgeon, but I won't let you know my bias. And what they propose to do is show you all these neat gadgets and toys that will make you look beautiful. So you don't want to be like this person who's going to have surgery. Of course, you want to look like this person. You want to be running on the beach with beautiful legs. Because if you do surgery, you're going to end up looking like this person. Okay, and that's the promise. That's what the internet can promise you. There's no need for objectivity. There's no need for data. There's no prospective studies. It's just, I said I can do it, and therefore I will do it. And you got to be careful. That said, I think there is room for advancement. This device actually was developed probably almost 10 years ago. This is a radiofrequency catheter, and it has these specific tines that supply the radiofrequency energy to the vessel wall. Radiofrequency is similar to what we use for electrocautery in the operating room, and various devices were used. It was thought that radiofrequency would help people with anal incontinence, because when you place this radiofrequency around their anal sphincter, it constricted the collagen, therefore it tightened their sphincter, and their incontinence was improved. So the original concept here was the venous restore catheter. It was going to restore that vein. So I talked to you about the valves, and they weren't working, so if I narrowed the vein and brought the valves back together, they'll work, won't they? So this was what happened. They used the restore catheter, and all the veins closed. They went, aha, now we've got the venous closure catheter, because it closes the vein. So that's how this was developed. So this is the generator. These are the catheters. And hopefully I don't kill everything with this video. Can you hear it?
Catheter electrodes are deployed, contacting the vein wall. Tumescent anesthesia is injected up the vein in the saphenous compartment to provide skin protection, sanguination, and compression of the vein onto the electrode. RF energy is turned on and pullback begins. This controlled heating of the vein wall causes shortening and thickening of collagen fibers to help shrink the vein. Endothelium is denuded, and the vein lumen is acutely narrowed. This stimulates fibrotic sealing and occlusion of the vein. When the electrodes reach the introducer sheath, RF energy is turned on and the catheter removed. The fibrotically occluded vein is resorbed by the surrounding tissue.
We didn't kill it. Good. So this is the initial series. Again, this was what we'd call a prospective registry. Now, problems with prospective registries is it means I'm going to put people in who had a good result, and the people who don't have a good result, I don't want to hear from you. And so, of course, it looks good because it's not randomized. Bad results don't happen. And as the series grew, it grew to about 300 patients, but they were only reporting about 160 of them. And I became sort of a thorn in their side, asking them for more data because they were advertising Ladies' Home Journal and various different lay journals talking about what a great device this was, and that really was unfair to their patients. And in fairness to them, they really have tried to become more objective and have shown that, in fact, this is a very useful device for many patients. It actually closes the vein 87% of the time at 6 months, 91% at 12 months. The recurrent rate probably is approaching 15% of the year, meaning that the vein reopens. And again, that may get back to the concept of that perforating vein I talked to you about that's still there, still connected to this vein and creating a high-pressure sink into this vein that may reopen it. Because the vein is still there, although the proteins have been denatured by the heat. Again, they perform the phlebectomy. That's the surgery part. That's the little stab incisions. So some physicians who are not surgeons tell patients you can have a venous closure and we don't have to remove those veins because they'll go away. Well, yeah, they do because the patient goes to see another doctor to get them taken away. So just treating the vein alone, the saphenous vein alone, won't lead to the varicose veins going away. You need to perform the phlebectomy or sclerotherapy or some other treatment of that varicose vein. In the early initiation of this, patients had a lot of paresthesia. The concept was actually described by a Polish surgeon in the 1960s, and he had so many burns from this procedure that the country made him abandon the procedure. And so when they recognized that they were getting this high incidence of paresthesia, that led to what's called tumescent anesthesia, where a needle is placed adjacent to the vein in a large volume of local anesthetic, or if the patient's under general anesthesia, a saline solution can be injected into the space right next to the vein and actually compresses the vein, but more importantly, lifts the skin above the vein so that the burn rate or the paresthesia of a nerve adjacent to it is markedly decreased. Well, if burning is good, then why not try laser? I mean, lasers work for everything. Laser means latest attempt to stimulate extra revenue. Okay, so we have a laser. We'll take a fiber and we'll stick it in the vein and we'll do the same thing. So basically you have a sheath, so this uses some of our newer endovascular technologies. You can use an ultrasound and you can identify the vein under the skin, not even make an incision, puncture it with a needle, pass a wire, this guide wire, up to the junction where it joins that common femoral vein we talked about, and then pass this catheter, and through that pass this fiber optic tube that has the laser energy. And this works the same way that the radio frequency does. It superheats the vein. There are different wavelengths used in these, and they're proprietary, so different companies have different wavelengths. They say that the lower wavelengths, the 800, the 900 nanometer wavelengths, absorb preferentially in blood, so they basically are superheating the blood. The longer, the 1200, preferentially are absorbed by water. But both of those, if they maintain a certain energy level at a certain rate, they will close these veins. It's a frustrating procedure because you've got to pull this thing back very slowly, so it's more time consuming. It takes much longer than a saphenous vein stripping. The newest generation, again by our friends at Venus, is really an advancement. This is the Closure Fast. I love their names, Closure Fast. Because it does go fast, because now they have this long segment. It's about 10 centimeters long. It's a metal, corrugated metal ridge that has a high opacity on ultrasound, so you can see precisely where it is. You place this in the vein the same way you place the old one, but now you can ablate that whole segment at once. and it has graduated markings along the course, so you pull it back 5 times and you've got the vein closed, much faster. And so this slide shows you the comparison of these closure techniques. The closure plus is the original, the granddad of them all. The fast technique is now radiofrequency, and the laser, as you can see, the times are now similar between the radiofrequency and the laser. But again, my preference would still be this newer fast device. Well, I'm sure many of you have seen a patient that looks like this, and these patients are miserable. This is what's called a stasis ulcer. Classic characteristics are this pigmentation for you skiers. This is in the gaiter region of the ankle, so just like where you used to wear your gaiters. And this is a typical location of an ulcer. The skin is very sclerotic. It's very stiff, unforgiving, not compliant like normal skin, and prone to these ulcerations that can be chronic and last for years. And untreated or unhealed, sometimes these ulcers can actually go on and form cancers within them. Again, compression therapy is useful. I can get that ulcer to heal if I have a compliant patient that will wear a compression stocking, and we can actually improve that by adding a little foam pad right over the ulcer bed underneath the stocking to add increased pressure to that ulcer bed. The original surgical procedure performed for these ulcers was called the Linton procedure. And basically, the patient was taken to the operating room, and the ulcer bed was debrided to make sure no cancer was there, to clean the wound of any colonized bacteria. A long incision was made, and the fascia that I told you about before, that sleeve that closes all the muscles in your calf, was open to allow more space. And then these slashes were where these perforators that I showed you previously were divided with a surgical technique. Pretty significant surgery for somebody who's already got compromised skin. And this is typically what you were left with 6 to 8 months later. And maybe you'd get this wound to heal, but this one would reopen. The patient still had the ulcer and didn't know why they'd come to you in the first place. Well, a German thought, well, wait a minute, you know, here's the bad skin, here's the good skin. What if I could look down here some way and divide these perforating veins without actually making an incision here? So he used this device, which is called a otolaryngoscope, and this is actually used by otolaryngologic surgeons or ENT doctors to look down the throat for cancer. It's similar to the type of device that would be used to put a breathing tube in somebody at the time of their surgery. So he made an incision in the healthy skin, slid this underneath that fascia, and then looking down this, it's a hollow stainless steel tube, he was able to put a device down and divide these perforators. That was refined. Dr. Fogarty here locally took an interest in this. The procedure was called SEPS, that's subfascial endoscopic perforator surgery. And Dr. Fogarty developed this device to create space under the fascia. Much like all of his inventions, it involves wine, so there was a corkscrew aspect to it. There was a balloon that was expanded that created the space, and then these are typical laparoscopic instruments that are used in laparoscopy. And this is an example that we did about 7 or 8 years ago. I think it was the last time I did it. So here's the port that's created. There's a space under here. With the ultrasound, we mark our perforators. This is a working port. You can either cauterize or clip these perforators. And in this particular patient, this is the view that you see. So this is that perforating vein I showed you before. So this is that fascia up here. The superficial vein would be above that. Perforating vein and down deep would be the deep vein. So we clip it, divide it, and you move down to the next one, clip it, divide it, move down. And so this patient came with an ulcer. These are the incisions right after surgery. And this was 3 months later. So clearly an improvement. But again, most patients don't need this procedure, and I've probably done 5 within the last 10 years. So a useful invention, useful in select patients who have problem ulcers, but in the majority of patients, it's superficial veins that have been the problem and have been unaddressed. And if you treat those veins, oftentimes the ulcers will heal without the added surgical procedure known as SEPS. Well, because I suggested to the manufacturers of the venous catheter that the perforators were the reason that these varicose veins were recurring, or the saphenous vein was reopening, they developed a closure RFS device. And so now this is a catheter with a metal trocar that under ultrasound guidance is inserted through the skin after local anesthesia into the perforating vein. The plastic sheath is withdrawn, and this metal radiofrequency probe is heated, and basically the idea is that you close off this perforator. The problem is that most perforators aren't as long as this cartoon suggests, and this is not easy to do, not easy to isolate these perforators and put this device in. This is a new device, again with beautiful videos to show how it works, but I'm uncertain if this is going to be an advancement or not. Well, sclerotherapy, something that we've all heard about, typically used for the small reticular veins, the small veins that are more of a nuisance than causing any symptoms. But in larger veins, with the creation of a foam sclerosant, there has been some interest in treating these larger veins. There's nothing magical about foam. Most of the sclerosants we use today are detergents. And you all know if you mix your detergent in your sink, you see a bunch of bubbles form. So if you take the detergent and aspirate it back and forth between two syringes, foam is formed. And so that was the concept. And the use of ultrasound guidance to deliver this foam into a vein really localizes it, because when you inject a volume of blood into the vein, it's going to follow the blood flow and it's going to leave. So with the addition of the foam, it's thought that it'll keep this sclerosant in place for a longer period of time and hopefully lead to more complete sclerosis. It remains to be seen whether or not that's really going to be seen. The leading advocates of this are in Europe. These are some pictures that they have depicting the success of this procedure. And again, the goal of this is to damage the endothelium to lead to a fibrotic stricture of this vein, causing it to close and therefore no fluid volume. In my own experience with sclerotherapy, it rapidly recurs. Once you start sclerosis of even the small reticular veins, it's a lifelong process. The beauty of the ultrasound, again, is that you can inject it into damaged veins through damaged skin, and so we have used it in some situations where it would be difficult to make an incision to remove a superficial vein, and the aid of this ultrasound-guided foam sclerosant has been helpful to us. So in my own practice, it's sort of a selective use. But if you follow patients who've had sclerotherapy, there is a high recurrence rate of reflux, 70–80% by 2 years, and a significant recanalization rate, as one would expect, because the vein's still there. Again, this has been a European advancement. These are the various the double syringe, the Tessari, all different ways to take your detergent and create foam. One of the problems with this treatment, and people have heard about and they ask for it, is that these agents, polydocanol still, and sodium tetradecol was and now is not FDA approved. And therefore, use of these agents is off-label, and if something bad happens, which can, and I'll show you what bad can happen with sclerosants, it's a significant liability issue. You can't even get it. We used to get it through Canada. There actually are some things known as compounding pharmacies. So you can write a prescription for your patient. They can go to this compounding pharmacy who will give them this sclerosant, because it's actually a drug that's used in other indications, so they have it. They just can't use it for sclerotherapy. And the patient can bring it back to you and you can inject it. And this is what Dr. John Bergen does down in San Diego at the La Jolla Vein Institute. So if you're really interested in sclerotherapy, perhaps you look up his beautiful website. But it has been successful. This study looked at comparison of foam sclerotherapy versus liquid sclerotherapy, and objective follow-up, duplex ultrasound at 12 months. And again, fairly good results, 13.5% recurrence versus 55% for liquid. So in some patients, there still is need for this, but again, locally we're somewhat constrained by the FDA in this problem. So this is typically how we perform sclerotherapy. The small, either reticular, in my own practice, reticular or telangiectatic vein is identified, cannulated. I'm getting old, so I use some magnifying loops to try and see the vein. Once I'm in the vein and I get a flash of blood back, I can then inject my sclerosant. And this is a typical scenario of your process. So you start centrally and work peripherally to try and take out the whole bed of veins. There are allergic reactions to these detergent sclerosants, so some patients will have severe anaphylactic reactions, so it's not completely benign. Other agents used are glycerin, which doesn't have any allergic reactions but is less effective, and then there's hypertonic saline, which causes significant potential for burning of the skin if it's extravasated out of the vein. If you've ever seen these spider veins that are exceedingly small and trying to get this small needle in and have it stay, when the patient gets pricked, they say ouch and they move. It's easy to get this stuff into the adjacent tissues and cause a burn. Recently there was this new device that's been brought onto the market, the vein light, which actually is helpful. And so in a darkened room you can use this illuminator. It's basically a halogen light that goes through fiber optics into this ring and it will illuminate the soft tissues and show you where this vein is, and you can get that vein with your injection. So this has been a help. when performing both the larger vein injections and even the smaller vein injections. So this is the typical kind of patient that would be treated. This is again a spider vein or a flame telangiectasia, typically injected at this nidus up here. And with multiple treatments, you can expect results almost as good as this at probably 6 weeks. But more not likely than not, this will be replaced over time with some smaller red blood vessels in a reaction because you've basically taken out all the drainage here, and so neovascularization happens, and new blood vessels develop, and you got to inject that area again. And this is the larger reticular type veins. Again, you can see each of the start points here, so if you get your sclerosis into these, you can expect to see a result like this. But if you get it outside the tissue, especially if you're using the hypertonic saline or a high concentration of the detergents, this is the skin necrosis one can see with sclerotherapy. So it's not a completely benign procedure, and I think one has to consider whether or not it's really important to them to pursue this pathway, because most of the time these reticular veins don't cause pain, it's purely cosmetic. Well, finally, to sort of close things out, the deep veins also can be a problem, and typically they become a problem because somebody's had a deep vein thrombosis that was probably not recognized and not treated appropriately during the acute setting, and therefore they're left with this chronic venous insufficiency. The deep vein valves are damaged, and so the thought is if I could fix that valve, I might help this patient. And so there has been interest in performing valvuloplasty with 5 to 10 year follow-ups. The major advocate of this is a very competent surgeon in Honolulu, Dr. Peter Kistner, who really had excellent results, but he selected his patients very carefully. Another concept was a valve transposition. So I take your axillary vein, which is working normally, and I transpose it down to your leg where your valve isn't working, and that should make you better. But again, what I talked about earlier is after the deep vein thrombosis is healed, some people, the vein never gets back to that compliant vein that we talked about in a natural state. So it's a thickened, rigid tube. So you take this compliant valve from the arm, you put it into this non-compliant, very rigid leg, and it fails very rapidly. So now you have an arm problem and a leg problem. So we kind of abandoned that. Then we thought, well, there's a lot of cadavers that are being used for organ transplantation. Why don't we take some of their valves and treat them in the same manner and then use them? And so we've tried that as well, and they failed the same. They've dilated and they've become incompetent over very short periods of time. So for patients with severe deep venous insufficiency, compression therapy remains the most important concept. And if the patient is compliant, they can live a reasonably normal life. This cartoon depicts the various forms of valve repair, valvuloplasty. Sutures are taken through the side to try and create a reef or tighten up that valve to make it competent again. They were actually done, you can make the incision above the valve, through the valve. Actually, this was innovative, taking an angioscope, which is a small lighted telescope, much like an endoscope, looking through a side branch down at the valve, and then from the outside putting a stitch through, trying to reef this valve up to correct it. Again, short-term success, no long-term success. In the era of endovascular treatments, what about taking a valve, a normal valve, and putting it on a stent, and then therefore you could deploy it percutaneously from a remote site? Neat idea. Able to do this in animals. This is a pig. See a beautiful valve. It's competent. It's working. But again, they put it in a normal vein, so of course it would work normally. This is a sheep. Again, this was after 6 months, so at 6 months this still looked pretty good. It was well incorporated. These are the fine little walls of the valve cuffs, looking excellent, but again, that's a normal vein, you put it in. Now this is an idea where you take some tissue from a cow and create a valve on this stent, and that's been used in 2 patients. One patient failed very rapidly. The second patient had a healing of his ulcer, is now about 9 or 10 months out, but no follow-up has been in the literature on this patient, and I suspect it's failed as well. And I think that the reason it fails is what we talked about earlier. The valves, again, talked about most of the valves are below the knee, and this is for treatment in the thigh or above the groin, where there's only 1, maybe 2 valves in the normal situation. But the reason people have problems is for the valves that aren't working below the knee, which are much smaller than we could ever make any percutaneously delivered device. But nevertheless, research remains ongoing. So in conclusion, venous insufficiency, modern greater saphenous vein stripping and perforator ligation is a durable procedure. Patients do enjoy early return to work. They're not in bed for 2 weeks like your grandmother told you. They have some post-procedure discomfort that's real, but is variable among patients. But it is more than patients with the ablation procedures, such as the venous closure or the endovascular laser treatments. The problem with the endovascular treatments is the durability remains unknown. Probably approaching a reopening of the vein of 15% of the year is a reasonable estimate. Sclerotherapy, again, best applied to these small reticular veins and telangiectasias. The foam sclerotherapy for the varicose veins has not proven any durability, and most of the preferred sclerosants used by the protagonists are off-label, most of it used in Europe. The patients with severe venous insufficiency related to their perforator disease, the traditional open surgery really has not been successful because of wound healing problems. Compression devices remain frequently the only method of treatment for these severely diseased patients. It remains to be seen whether or not ultrasound-guided sclerotherapy will enjoy some success, and these newer attempts at ablating these perforators percutaneously. Again, sepsis in my own practice is very limited for a select few patients. And as far as the deep veins, valvular repair is again used infrequently. That's because of the failure rate is significant. The deep vein valve transfer similarly are creating a problem in a healthy limb and not curing the problem in the diseased limb. And the percutaneous valve delivery remains an interesting concept, but hasn't been proven to date. So if you follow these simple rules, you can have grateful legs like this. Thank you for your attention. Okay, questions? Yes. Well, it's been studied extensively, and I'm not sure we still have a complete understanding, but it's thought that the back pressure, the hypertension that builds up in the veins, is transmitted back through the capillaries. Remember, arteries bring down blood to the capillary level. In normal flow, there's some fluid and nutrients that leak out the capillaries into the adjacent tissues to get their oxygen, their glucose, and everything. And then it's collected back into the venules and back up the leg. So you imagine if you stop the outflow of the blood, the pressure builds up in the venules, in the capillaries, and more exudation of fluid happens. The pores for that exudation become larger. Proteins leak out. Red blood cells leak out. They die. Their proteins are trapped. It leads to more sclerosis. And so it's thought that now oxygen, glucose, those nutrients can't get to the skin because of this increased interstitial, meaning the pressure within those soft tissues, pressure. And so the compression forces the blood to stay in the vein, back up to the heart, and that actually is why we think compression helps heal these. They've looked at microscopic samples from these ulcers, and they can find fibrin cuffs to document that protein is leaking out. They've tried wound healing factors, such as been used for diabetic foot, and that hasn't helped so much. So it's a complex problem, but it has been observed and associated that if you get rid of that interstitial pressure, the ulcers will heal. Sleeping on two pillows causes venous reflux disease. You mean two pillows under your legs or two pillows under your head? Well, it certainly can increase the hydrostatic pressure to the vena cava, but again, all the valves are located below that. In a normal state, it's unlikely that you would have enough pressure just from elevating your torso 20 or 30 degrees to cause a valve that's competent to become incompetent. So imagine a pregnancy, the blood volume in a pregnant woman increases, 130, 140%. And so in some women, that will cause the vein to enlarge to where the valves don't work anymore. They'll develop varicosities during pregnancy. And for most of them, when the blood volume returns to normal, the vein shrinks again, the valves become normal again, they don't have varices. So it can happen that increased pressure can cause temporary incompetence, but not prolonged. What danger do you have if you happen to cut or traumatize a vein and it starts bleeding? A varicose vein. It's low pressure, okay? So if you just elevate it, it'll stop. You can put your finger on it, it'll stop. But most people panic when they see it, and they don't do either of those things. They just watch it bleed. And so that could be dangerous. But, in most situations, it's not superficial enough that it would be susceptible to easy trauma where it causes bleeding. Swimming is especially good because when you're underwater, there's pressure provided by the water, the pressure of the water on your limb, so it compresses the vein, and you get the exercise of movement. You need some movement. The muscles have to be moving to pump the blood out. And the reason that standing or walking is improved is because of that lake of blood under the sole of your foot. That's why you have an arch, and when you stand, you flatten that arch, pump that blood out. In fact, in orthopedic patients who have their knees immobilized after a surgery, the device they use to prevent blood from pooling or causing stasis is a little impact hammer that hits the bottom of their heel rhythmically on the sole of their foot. And that pumps the blood out when they can't use the sequential device on their leg because they've got a brace or a cast in place. I wouldn't demean acupuncture. It may work. It does a lot of things for a lot of people. It's vascular tone, so it might improve vascular tone, but somebody with really severe venous insufficiency to the point of development of these large varices that we were talking about, I don't think, no matter what it was, even, a sympathectomy would cause significant enough vasoconstriction to make a difference, but don't see any harm in it. Do most people seek medical treatment or surgical treatment for medical problems or cosmetic problems? The ugly truth is that most people are embarrassed, and so they come into my office, and oftentimes it's 2 or 3 visits before they'll actually take the sheet off and let me look at their legs because they feel like they shouldn't be here because it's a cosmetic thing. And that's too bad. That's our society has done that to people. To compound that, our insurance companies have said, you're being vain and therefore we're not going to pay for this. So there has been a change, but there are several very prominent insurance companies that make you jump through many hoops, hoping that you'll get tired and say, forget it, I don't want to do this. And so the majority of patients that come in do have discomfort, but obviously are interested in the cosmetic, and that's why we try these newer techniques to give them a cosmetic result, even though it's a functional operation. And that's the way I approach it with the patient, that's the way I approach it with their insurance companies, and I think we're seeing a change, but again, I'm not kidding. People will come in and won't show me their legs for several visits before they get the courage up to say, I really want to do something. I mean, why did they come all that way? It's not easy to get to our office. We live in the back of the hospice, a long way to walk, They get all the way there, they get undressed, and then they don't show me their leg. I mean, it's sad, but it's real. Yes? No, she says, would prolonged walking and hiking over the years lead to the development of this problem? No, in fact, I would suspect that has probably prevented you from developing, fulminant. It's more the people who, and now today seeing software engineers who sit in a sort of a weird position for 10, 12 hours, with just pure stasis in their limbs. Those are the ones that are getting varicose veins. Factory workers, assembly line workers, who are forced to stand and just move their torso, their legs weren't moving at all. That static pressure was causing varicose veins. But activity is a good thing. I have used both. Again, I think that the laser devices are very tedious and take me much longer to do, and unfortunately, time is money. So I think the Venus Fast now, that new device, is nice. It does do a nice job, and it is much quicker. And I can focus more attention onto the tedious part of the operation, which is the phlebectomy part. But because I've been doing it for such a long time, I can do a stripping faster than both of them. But then that's a groin incision, so many patients don't want to have the groin incision, and those are the patients I would offer the closure. Pardon? Yeah. Yes. Okay, she says we're done. All right, thanks for your attention. All right.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.